Hello and good evening, everyone, and welcome to this online dialogue on prehabilitation and rehabilitation with the lung cancer journey driven by Lung Cancer Europe. My name is Alfonso Aguaron, and I will be moderating today's session. So today it is my pleasure to introduce you to our three panelists, Dr. Mathew Evison, consultant chest physician at Wythenshawe Hospital in Manchester University NHS Foundation; Hilary Neal, clinical nurse specialist at the Christie NHS Foundation Trust in Manchester, specialized in lung cancer, and also a member of Lung Cancer Nurses UK; and Grainee, cancer rehabilitation physiotherapist at St James Hospital and postdoctoral research fellow at the Exercise Oncology Research Group at Trinity College in Dublin. So on behalf of Lung Cancer Europe, I would really like to thank you, the three of you, your kind acceptance to participate into this session and such an interesting hot topic for the lung cancer community and for especially for patients and caregivers that we have today in attending our session. So before we get started, I would like to explain how the dynamics of the dialogue. So I'm going to start asking every one of our panelists an introductory question just to set the ground, and then we will continue with an open discussion. All of you who are attending the session can send your questions or comment via the chat or the Q&A window in the Zoom application that you just downloaded to join the session. You just send that at any given time, and I will read them to our panelists today. So without further ado, I wish you all a very fruitful and interesting discussion. And so I'm going to start with the first question to you, Dr. Evison. So from your perspective as a physician working with and treating patients and people living with lung cancer, what do you find are the major physical issues for a person who is diagnosed with lung cancer that comes for the first time into your practice?
So good afternoon, everyone, and many thanks for inviting me for this discussion, an important discussion. So lung cancer, like many other cancers, it leads to an inflammatory state in the host. And that inflammatory state drives a very wide spectrum of symptoms and outcomes that affect someone's physical health, affects their mental health, their psychological well-being. And that is probably the biggest single area and the biggest priority area that we can address, that we can help support and change in someone's cancer journey. We can't, we have no control over the response to treatments and the biology of individual tumors, but what we can have a huge impact on is the physical and psychological well-being and preparation for and recovery from treatment. So we often see that this inflammatory state can drive an effect on appetite and a loss of appetite. It can drive muscle loss and fatigue that drives inactivity, and all of those things interconnect. That means that very often someone is becoming less active, feeling more unwell, with less calories to fuel what they're doing day to day, and all that is the perfect storm for deteriorating health that then has an impact on the tolerability of treatment and the impact of treatment, the risk of side effects, and the recovery from it. So the generalized impact that cancer has, it's not unique to lung cancer, but it's very prevalent in lung cancer. That the impacts are profound. And as I say, it's the one area that we can focus on that can be of huge benefit, but not just for us. It's the one area of focus that can be for a patient in a positive way. One of the most common things I hear is how much it feels like you lose complete control when you're diagnosed with cancer. You have no control over that diagnosis. You have no control over what's just about to happen to you. But the part you can control and sometimes regain some control over is those parts of the life around nutrition, around activity, around psychological well-being, if the right support is there to allow them to do it. So I think it's such a critical part of cancer care that has probably been neglected in many ways for a long period of time. It does feel like the focus is really coming in on it now, but there's a lot of work to do in it.
Thank you, Sheill. So what I understand from what you say, and probably we'll touch base on this later, that this is just not kind of disease or situation that can be just focused on just a single field, but needs the collaboration from many different fields and areas of expertise, and that's how we are lucky to have a good representation of three major figures today with you. So Hilary, I will continue with you. So from your perspective as a nurse caring for people living with lung cancer on a daily basis, what type of support in coping with the symptoms and side effects of treatment you are providing in your unit? What are the most common care support that you are providing?
Yeah, well, good afternoon again. Thank you for having us today. I mean, firstly, I just wanted to echo what Dr. Evison has said there in terms of the presentation of patients when they come to us. And, you know, from a nursing perspective, when we are sitting with them and in the initial consultation, we're going through an awful lot of information about their diagnosis, about the science behind it, you know, all the technical stuff that has led them to that diagnosis. It's a huge part of it, as Dr. Evison said, is out of their control. They have nothing that they can, you know, they can put their finger on and say, I can help manage my response to treatment as I go forward. But, you know, the aspect of improving their physical activity, improving their mental health, improving their diet are things that they can focus on. And as they go through treatment and as I help support them, you know, they have from a wide spectrum of side effects from the treatment, but also symptoms of their cancer as well that I help support them with, such as, you know, commonly breathlessness, commonly fatigue, loss of appetite, and other things associated with the chemotherapy or particular therapy that they're having. So there are a lot of areas, and I think as a nurse, we look at things holistically. We don't look specifically just at their physical health and the things that they present with, but how do they cope with those situations? How do they cope with the symptoms from a psychological perspective as well? So I see my role very much as supporting patients from the point where we meet them at that initial consultation, all the way through encouraging them to maintain their activity, encouraging them to increase their oral intake when things are tough, you know, when they may have side effects that prevent them from eating as much or the same foods that they used to eat, and getting them through psychologically, keeping them motivated and maintaining that level of hope that this treatment is going to work. And that's a tough thing for anybody to go through.
Right, that's quite interesting. I think it's quite aligned with what Dr. Evison said. And Grainee, I'm going to continue with you before going into the topic of rehabilitation, which might be not so familiar. Sometimes when we found in LuCE that when patients think about physiotherapists, it has to do a lot with rehabilitation and so on. So many people living with the disease report many issues that prevents them from being able to cope with daily activities. So just to grab the big picture, how from your area of expertise, how do you feel physical rehabilitation can help in this matter and so improves the patient's quality of life?
Yeah, thanks. And thanks for the invitation to participate. I think where a rehabilitation physio comes in is to look at, well, everyone really should be active. And I think a lot of the general health benefits of exercise are well known, but we're looking at exercise to specifically target some of those side effects that have been mentioned already. And what a lot of people need is maybe help just adapting exercise. So maybe they did exercise before and no, that's no longer maybe the most suitable exercise for them to do, or they can still do it, but need to adapt it in some ways. And that's really where we would, try and work with the patient and say, well, this is, a suggestion for how you could change this or modify this. And give them all of the tools they need, to stay active, whatever type of activity they want to do. And we can advise them on what would stand to them, what would be the best recommendations, and also say, well, how are we going to do it? And I think that's really important, because like you say, there will be difficulties maybe that
I'm not sure if we have lost Grainee. Maybe. Yeah, I think we have lost her. Oh, here we go. Sorry, yeah, I think you just disconnected for a moment, Grainee, but we can hear you now again. No problem.
Yeah, I was just talking about that message of trying to stay active throughout the pathway. So from where you've just got a diagnosis and you're not sure what treatment lies ahead, to maybe going through treatment or recovering from treatment. And that's really what we're there to do, is to try and adapt kind of what activity people can do so that they can manage it no matter what stage of treatment they're at.
Great, thank you so much, Grainee. So I would like now to touch base, and I'm going to open the floor for any one of you who would like to intervene, which is about the concept of prehabilitation in lung cancer. So while we found many patients are familiar, as I said, with rehabilitation or coping techniques to like nutrition, exercise, things like that, they are not so familiar with the concept of prehabilitation. So from a clinical nurse and physiotherapist perspective, first of all, would you be able to explain exactly what do we mean with prehabilitation, first of all? What could be the advantages of things like, for example, preoperative respiratory muscle endurance training, or could you explain which kind of tactics or methods in prehabilitation could be useful for lung cancer patients?
Yeah, should I go for that? So I think if you were trying to give a definition of prehabilitation, it would be the physical and the psychological preparation for treatment. And if you think about, there's a very famous graph in prehabilitation about if you've got time on one axis and someone's physical activity on or physical status, functional ability on the other. There's always going to be an impact from treatment. There's going to be a negative impact that's going to take time to recover. But if you've undergone prehabilitation, your functional status should be increasing to a level higher than it was, so that the impact of treatment is lower and the recovery from treatment is quicker. And ultimately, the best goal and outcome of prehab and rehab is that it changes health behaviors in the long term and creates new, longer term sustainable health behaviors around good nutrition and physical activity. And I think that it all makes sense. It makes complete sense. I don't think there's nobody in the world who would say that's not a good idea. We've got the evidence behind it, particularly in surgery. I think it will come in oncology as well, but in surgery, it's nailed in. So there's been in thorax last year, in the journal Thorax, there was a meta-analysis that synthesized all the existing data, very high quality meta-analysis. And that showed that with prehabilitation, you reduce the risk of post-operative complications by about 50%, and you save about 2 days of a hospital admission. So really clear evidence that there is a strong benefit So a 50% reduction in perioperative complications is huge. And that's just looking at a few specific variables, let alone the longer term impacts and benefits. So I think the evidence is overwhelming, and just the common sense, you say it out loud, everyone is behind that. The difficulty is how do you implement, how do you actually do that? And prehabilitation is a multimodal intervention that isn't just exercise. It's physical activity, it's nutritional support, it's treating tobacco dependency and any other dependencies of harmful substances. It's psychological well-being. It's a multimodal intervention. So how do you deliver that at scale? Because everyone, I think, is behind it, that should be a standard of care for every cancer patient, not just for lung cancer patients. I can talk about our experience locally in Greater Manchester. So we're a region in the northwest of England that's got a population of just over 3 million, quite a dense population in a very urban area. And we have around 2,500 to 3,000 patients diagnosed with lung cancer every year. And there's been a real drive from the cancer network across that region to ensure that every patient gets prehabilitation. And it's going through a process of, it's not at the point where every single cancer patient gets it, but it's really come a long way in the last 3 years. And it certainly has in lung cancer. And one of the ways that it's been successful is that it utilized an existing infrastructure in the community. So across Greater Manchester, there were nearly 90 different community leisure centres or fitness centres that are out in the community as a publicly run service. And our programme then utilised that framework, and it created a collaboration between the health service and the leisure sector. And so we have a team of exercise specialists that are trained to a cancer rehabilitation level, and they use those community locations to deliver a prehab programme. And they're trained to deliver nutritional interventions, psychological wellbeing interventions, and provide a physical activity program that's supervised by them within these institutions. And by using that existing framework, we've got a system where if I see a patient that's been diagnosed with lung cancer, I can make a referral to that team, and within a day or two, they'll contact them and invite them for an assessment in the community. And because we're using these 90 different locations, there's one within about a mile of anybody's house in the region, so that it can be close to home, where they can be assessed and an individualized package created for them. And it's very prescribed in the prehabilitation phase. So it's very much trying to hit target heart rates and specific strength training exercises that are individualized to what that patient can do and their health needs and their comorbidities. Very supervised, very structured. When their treatment happens, during their treatment and in the recovery, that very much then switches to trying to create programs that really fit that individual's needs. So less standardized across everybody, but individualized to really try and encourage engagement. And they get 12 weeks of rehabilitation afterwards, with the hope being you're starting to change health behaviors in the long term. And we've now got to the point where every lung cancer patient that is undergoing any form of treatment, whether it's surgery, whether it's chemoradiotherapy, whether it's systemic therapy, whatever it is, they have access to this program. And that's gradually increased over the last 3 years. And there are other cancer pathways where it's in place, and we hope that it gets expanded more and more and more as it grows. And it's undergone some independent evaluation to show that it is money saving to the cancer system. So it releases beds in critical care, very particularly in colorectal cancer, in some of the evaluations that were done. So the cost of the program pays for itself because of the savings it makes in releasing healthcare resource. So that program is a brilliant program, and the people that have led it, you know, need great accolades to what they've achieved in getting that in place. But it has been through collaboration with existing exercise networks. So it's been using those networks to deliver it, because far too often you find clinicians that really think we should have a prehab program, and they work their socks off to get a physio or a dietitian in their clinic who can do brilliant things for the patients in that clinic. But it's centered within one clinic, within one hospital. You know, the reach of it is at a sustainable and scalable model, where to try and get standardization of prehab and rehab for every cancer patient. So I think the evidence is there. It's unquestionable that this should be a standard of care. Everybody believes in it. Everybody wants it. The challenge is, how do you actually implement it? And what works in one place might not work in another place, but there has to be, it has to be at a system level, so that you create something that's very sustainable and resilient and can grow.
Yeah, that's quite interesting, and this will link with the question that I have for you all later. But I'm not sure, Hilary or Grainee, if you would like to add something on this respect.
Yeah, I mean that you know, we're very fortunate in Greater Manchester because of the service that has been developed. So we've got a fantastic service to refer patients to. I think from my perspective, it's you know, it sounds fantastic from our perspective. It works in terms of health economies. It's helping the patient through treatment from not just a physical perspective, but psychologically and nutritionally. But having that discussion with patients up front, sometimes, you know, there's a lot going on for them. There's a lot of information that they're taking in at the time of that consultation, and to sort of sit down and talk about engaging with you know, a team that are going to look at things that perhaps they've never thought of, things that they've never considered getting involved in. You know, we have people presenting with varying degrees of fitness, not just from a physical perspective, but, you know, psychologically and socially. And so that, you know, that's the difficulty, I think, sometimes is at what point do you have that discussion, and how do you make that you know, approach, you know, in a way that they want to engage in that. And actually, you know, that comes back to the element of control again, and trying to sort of to give them something that they're able to say, actually, if I focus on this is going to help improve not only tolerability of treatment, but being able to get through it, and hopefully sort of patient, you know, their outcomes at the end, and the longer term view as well. So I think from my perspective, it's that, you know, when do we have that discussion? How do we have that discussion as well? And how do we sort of develop those change in health behaviours when not everybody comes to that consultation with the same view?
Great. Yeah, sure, Grainee.
Yeah, I would agree. Can you hear me?
Yeah.
I think that piece around that kind of conversation with people is so important, and often this needs to be done in a short period of time. So time is of the essence with prehabilitation, and certainly, you know, with lung cancer, and that's a kind of important consideration to give as well. We want patients to start programs as soon as we can, and it's trying to build up the skills to have those conversations around changes that maybe the person, you know, they're big changes for the individual, and you're doing them in a short period of time. What does tend to help, though, is that it is something patients can take control of, so that the patients can take a little bit of their health and their well-being into their own hands in preparation for the surgery up ahead. And for some people, that's very encouraging, and it's a good incentive to, you know, to embrace these programs. So yeah, I mean, the difficulty is time, is getting people onto the programs quickly. And then you have that piece around trying to do health behavior change in such a short period of time. But often, because you are encouraging patients, I mean, the patients have to do, you know, the work. We can give them the information and the advice, but they have to make the changes. And for some people, that can be really empowering. It's why it's such an important moment in terms of behavior change, and patients can really take this on board as something they can do to prepare for the treatment that's up ahead.
I think, yeah, it's like what you mentioned, I think makes total sense, like providing the tools, the techniques, the abilities and the skills so the patient can really go through that. And I'd like to touch base based on, Dr. Evison, I think you raised your hand.
Yeah, I was just going to come back on, because I think there's some really important points raised there. So one is the conversation that does need to start at the earliest possible moment, and I think there's a real responsibility on the healthcare professionals that are that can introduce this at a very early stage. I'm thinking about chest physicians who may be the people who give the diagnosis, and I've for a long time heard apprehensions about what, I've got it in a clinic appointment, I've got to tell someone a diagnosis of lung cancer. How can I then go on to say we need to talk about exercise? And I've had the exact same thing with tobacco. Well, they've just heard terrible news. How can I have the conversation with them about trying to stop smoking, or that could jeopardize our relationship? And generally, I've found those apprehensions have often come from it's a lack of training in those areas, because they are difficult topics. And I my experience is that if we, as a doctor, if we spend 40 minutes with a patient, and 35 of them are about the diagnosis and the treatment, and that last 5 minutes is, oh, and by the way, I need to talk to you about exercise. I think you should try and get yourself a bit fitter, and really, if you can, you should think about your smoking maybe, and thanks, goodbye. And if we spend that amount of time on it, what does that say to a patient about how important this aspect of it is? We kicked off this webinar by saying this is the area we can focus, where we can really make a difference. So purposely, we'll try and spend an equal amount of time on the importance of these areas. And then when you've got the right training, those conversations become very, very productive. Tobacco is all about treating tobacco dependency, and it's about appreciating the illness and the disease of tobacco dependency, not a choice that someone quits or stops doing. We facilitate treatment for tobacco dependency, and that's a whole different conversation, and it's a much more productive conversation and a much more empowering conversation. And I think it's the same with prehabilitation, and it's how we explain it and discuss this with patients and the time we spend on it. There's a really good resource. It's a website that's www.movingmedicine.ac.uk. And I think it's Sport England and the University of Oxford and a few other people that put this together. And it's all about how do healthcare professionals talk about physical activity within consultations. And it is across the healthcare system, but there are specific cancer ones as well. And they'll do things like, if you've got 5 minutes, how can you use that to the best? And it's dead simple things like, instead of saying, I think it'd be really beneficial if you improve your physical activity, if you say to someone, do you think it would be beneficial, or what do you think the benefits might be if we were to be able to help you be a bit more active? And then it's just that very, very slight tweak, but it's the person that is then generating the reasons behind it that might cement it within behavior change a little firmer than being told it. So dead simple interventions, but I find them really, really useful that you can implement. And I think it's just so important that the responsibility is on all clinicians. And it's not just, it can often be put on the shoulders of Hilary and the the cancer nurse specialists. They've got so many things to go through with patients, and welfare rights to everything. We've got to take lots of responsibility in being part of that conversation, which makes it easier for everyone else who then picks it up.
So listening to all of you, there are many questions that come to my mind. Just want to mention, I just paste the link to moviemedicine.ac.uk in the chat for those of you attending who want to access their website. So thank you very much for sharing that. I just want to remind, if any one of you would like to ask any question or make any comment, you can do by typing that in the chat, or yes, if you raise your hand, I can unmute your microphone so you can do your question live. And I would like to, based on what we just discussed, I mean, you have presented, for example, what's happening in Manchester, which is that you are a great example of having this program implementing a standard of care. However, from Lung Cancer Europe, what we heard from many of our members, which are patient organizations, that this is not something which is usually implemented in a systematic way. And sometimes it's like, you know, for many different reasons, sometimes because for lung cancer, there has been a nihilistic approach for many times in which doctors sometimes has just focused on treating the patient without not, I wouldn't say not paying attention to other aspects, just trying to treat the disease rather than taking care of the patient. In some other areas, it could be the difficulties to have the proper healthcare professional, these multidisciplinary care teams in smaller centers and so on. So first of all, I would like to, even though you have mentioned that, but just to summarize, it's about the benefits. So what benefits from your daily practice you find in the optimization of physical and mental health through needs-based prescribing of exercise, nutrition, or psychological intervention, just to mention a few. Whoever wants to, yeah.
I hope you can hear me. I think some of the research kind of the benefits that have been proven through research are mentioned already, and they are the big outcomes in terms of increasing someone's fitness, then reduces the chance that they'll have post-operative pulmonary complications and have to stay in high dependency beds for a long time, or have to stay in the hospital for a long time. And then that review also showed that you reduce the length of stay. So there's other benefits in terms of the amount of the lung function of the patients and how we preserve some of their pre-operative function as well. So they're kind of the benefits that have been shown through research, and there's lots more research being done now looking at the kind of outcomes in terms of health-related quality of life. So actually, is someone's experience better if they're better prepared for the treatment that they might undergo? And I think some of the other benefits that need to be mentioned are, the patient is prepared then often for what's to come from surgery. So early mobilization would be standard of care post-surgery, and the patients are often more prepared for that and engage in their post-operative care when they've had rehabilitation pre-operatively.
Interesting. And if I may ask about thank you for sharing the link to the paper, Dr. Evison. And on the other side, it's like when we think about the challenges of this systematic implementation, and we're lucky, Hilary, that you're here. We were witness in the last few weeks what happened in UK with all the issues with the strikes for nurses. Sometimes it's all about resources. Sometimes it's not about having the proper methods in place, or sometimes it's just health system not well adapted to provide these means and resources to really have this implemented. What are the challenges and the barriers that you find in being able to provide this proper care to patients and the standard of care, and not considering like prehab or rehab like a kind of a state of the art? Well, we think it should be something that should be prescribed just as a drug or a treatment or a certain type of surgical intervention, just to mention a few.
Yeah, I mean, I agree. I think we're very lucky in Greater Manchester with the setup that we have. You know, we do have it Prehab now as part of the pathway. I mean, it is set up to refer every patient that comes through to that program, and that's developed over a number of years. You know, more recently, we've been able to refer patients who are going through systemic treatment for advanced lung cancer, which is something that's new but equally as important to optimize people's you know, fitness for being able to tolerate the treatment and get the best out of it. So we are very fortunate we've got that set up, and I think it's unfortunately not the same across the rest of the UK. They don't have that already set up. But I mean, Matt will know much more about, you know, how we can roll this out across wider trusts and areas across the UK, so that it does become part of standard of care, and it is a, you know, the benefits have already been explained, where we're getting cost savings from. So it's just a matter of being able to roll it out, which obviously is a huge effort.
And I might come in, I hope you can hear me. I'm in a different centre, in a very different setting, and we don't have the community resources that are, you know, really ideal for rolling something like this out into the community. But we had a really good group of key stakeholders within our hospital that were really interested and invested in this. So although we didn't have the community support, we were able to do in-house, you know, and start, I guess it takes time, but we have an in-house program now that was really driven by people with an interest in that in our own hospital. So it's trying to bring those people together that have the interest in this, and that could be anesthetics, surgery, or specific medical oncology groups, and trying to get all of those people, you know, around the table to put their energy into this and to look at what positions might be valuable. And what we found is maybe having protected positions, so having prehab positions gave some long-term protection then when there was really a lot of pressure on the hospital systems, because those people were protected for prehabilitation and they were less likely to be brought onto the wards. So by trying to get some specialised staffing in prehab, it allowed the service to grow. And we started with, you know, a small number of tumours, looking at a very specific program and group, and that grew as the expertise in prehab grew over the years. So that's a different perspective from the service that might be, we started in 2018, so might be a little bit newer and in a different setting to the Manchester experience.
Interesting. Very interesting indeed. I wanted to touch base in another point that was mentioning, that it was the smoking dependency, which I think is important. We still know from LuCE that this is there is a lot of stigma still around the fact of smoking, and that some people who is diagnosed with the disease and has a longer smoking history tends to be less adherent, has this feeling of guilty. Unfortunately, we've seen how through the years there is a different approach of non-blaming the patient or just consider this like a kind of bad habit or something like that, but more a dependency that, as you mentioned, Dr. Evison, needs to be tackled and handled in the most proper way. So even though we know now not all diagnoses relate to smoking, and we have known smokers with lung cancer as well, there's still a very important percentage that is related today. So from your perspective, from the different points of view, what is the most up-to-date approach to help patients who smoke to quit? How do you feel this is to quit if they, I wouldn't say if they won't, but, you know, try to empower them to quit this dependency or to help them? What are the approaches that are being used currently?
Shall I start with that? This is my favorite topic to talk about. You have to shut me up about it. There are so many highly evidence-based interventions out there. So there is more help than ever before. the real tragedy is that the vast majority of people that smoke don't get access to those, and a big barrier to it is the education and training in healthcare professionals. You know, right from medical school, university type level, we're not taught the disease of tobacco dependency and how to treat it, because it is stigmatized as a lifestyle choice that someone chooses to do. It first starts with providing the appropriate information and advice, and that is not an instruction to stop. Our role is to offer help, and that is a simple switch in mindset. That often begins, one of the most powerful things to tell somebody that smokes is the truth about nicotine. That's where it all begins, and it's where misinformation begins as well. That nicotine is the driver of this very, very powerful dependency. But nicotine itself is not a harmful chemical in any way. It's the mechanism by which that person gets their nicotine that does all the harm. So the combustion of tobacco creates thousands and thousands of toxic carcinogens, chemicals that create cardiovascular disease, damages every organ in the body. So the way of treating that is to use nicotine that isn't from tobacco. And a massively important switch in language and in approach is that we are trying to create this world that is free of tobacco, that is not necessarily free of nicotine. And that nicotine, it's a very similar drug to caffeine. They work on different chemicals in the brain. But just like people use coffee every day, you can use nicotine every day. And it's just where you get your nicotine from. So there are lots of ways of doing that. Now, you can use nicotine replacement therapy, but it's got to be prescribed right, because nothing gets nicotine into the body quicker than inhaling cigarette smoke and tobacco smoke. So you're up against the hardest challenge to try and recreate that in any other way. If we're giving nicotine replacement therapy, we give it in combination. So you have a long-acting, the highest possible dose that you can get, and a patch, and a short-acting product like a gum, spray, lozenge, all of them if you need it. And you give them together, and you give them in the highest possible dose, because you can't overdose on it. Nicotine's harmless. You can't take too much. You can only take too little so that you still crave to smoke. The other way of getting nicotine is with vaping, and this is where there's huge misinformation, disagreement, even across the medical profession, and different approaches in different countries. Vaping heats a liquid nicotine that the user inhales. It's the one thing that can get a hit of nicotine that isn't too far off what a cigarette is, which is why they're so popular. But there's no burning of tobacco. They are dramatically less harmful than cigarettes. There's no doubt about that. And pretty much internationally, there is widespread agreement about that. The best form of medical evidence that we have, particularly in the UK, is the Cochrane reviews, the most robust evidence generating mechanism that there is, the Cochrane review. There's a live Cochrane review, which means it updates continuously, that looks at the evidence for vaping, and it's now shown with high level certainty. So to reach high level certainty, it means there probably won't be evidence that can change this, that vaping is more effective than NRT. It's one of our most effective treatments for tobacco dependency, to get someone tobacco free. And then we've got tablets that are nicotine analogs. So they're not nicotine, but they work like nicotine in the brain. And this is varenicline, which is Champix, Zyban, which is bupropion, and cytosine is the other one that's not often known about. Cytosine is just a plant-based, naturally occurring nicotine analog. You can buy it on any internet seller like Amazon. It helps people to stop smoking. It's not a prescribable medicinal product. It's a consumable product. So I've just listed a whole range of them. We've got some problems at the moment because Champix isn't available. It's been there's an international recall because of a contaminant. So at the moment, the most effective intervention there is vaping, but there's loads of misinformation about there. There's different international policy around it. We've got NRT, we've got medications, whole range of them, and you can combine them all. and to give someone the best chance of stopping. And when you combine that with the support of a specialist trained in helping someone to stop smoking, that's when you get your most, your highest quit rates, which bring massive benefits. And just in lung cancer, at the time of diagnosis, if we help someone to stop, they will live longer. They'll have less complications from treatment, less risk of recurrence after curative intent treatment, all highly evidence-based. So a huge intervention. We can empower someone with that information. Just the information about nicotine can change how someone thinks about it. So there's lots we can do, but as clinicians, we've got to empower ourselves with the knowledge and the ability to prescribe and provide access to these treatments.
Yeah, I'll add to that as well, Matt, because I think the misconceptions around smoking and nicotine is really important. But the other side of it as well is you're just telling somebody that they've just been diagnosed with a lung cancer, and the last thing they want to do is give up the thing that they that is their crutch. Really, it's their go-to thing that helps with stress levels. It helps them feel better. So it's a tough conversation to have with people, but counselling them on the benefits of stopping and the benefits of not having tobacco is so helpful. And I think that takes a couple of conversations. It's not something that just happens, at an end of a consultation. As Matt said, it's very difficult to kind of fit all of that into one conversation. So I find a lot of the time I'm following up with patients later, and we're then having a conversation about, well, how can you help yourself? How can you manage this situation better for yourself? Take control, and that's another way that you can do it. So it's sort of several pronged approach. I think if that conversation starts right up front with the test physicians, that's really helpful, and then referring to the teams that can help. We've got cure teams at the hospital that Dr. Evison works at, and we have a smoking cessation team as well, and also help with alcohol dependency and other things that people struggle with. So it's a difficult conversation to have, but it's a worthwhile one to have, and to have on several occasions. And it's never too late to stop. And I think that's one of the things that people think, well, I've smoked all my life, I've now got a lung cancer diagnosis, what's the point? And there's always a point, there's always a benefit to giving up at this point. And it's just about having support, and the right support to help.
I think Dr. Evison, you wanted to add something. I saw your hand.
Yeah, I was just going to say it is that point that the apprehension is that I've just told this person they have lung cancer, and now I'm going to say, I think we need to, you can have it in your mind is, what I'm going to say is, we're going to take away this thing that gives you pleasure, that you rely on to be able to cope, a stress reliever, the thing you turn to at the darkest moments. And that is, again, I think it's about having the tools to be able to approach that with what can seem very difficult, but with the right understanding and knowledge can be actually a really productive conversation. Because what they're describing is the effect of nicotine. Very well described. It's a psychoactive drug. It has pleasurable effects, full stop. It reduces anxiety through dopamine, makes you feel calmer. That is the effect of it. And that's what the worry is about, losing that effect. But once we understand that you can still use nicotine, just not, we don't want to use it through tobacco, because it comes with all the harms associated with it. It's why for some of those most dependent smokers, and I've met so many now that have said, there's not a chance I will ever be a non-smoker. That is part of me. I will always be that. But through that type of conversation, particularly vaping, because it's the same action, same inhalation, same something hitting the back of the throat. There's the same deeply embedded habits are there, and it's the one thing that can give an experience of nicotine that is as similar to smoking tobacco as anything else. So it's preserving the experience. So for that person that is so dependent on it at the worst time of their life through a cancer diagnosis, where they would turn to that, they can still turn to it and still experience the same things. We're just taking away the harm of tobacco. And that's a very different conversation to feeling like, well, what I've got to do is persuade this person's behavior to change. And that's really difficult. Actually, we're going to switch their source of nicotine. And that can be a really empowering conversation. And those people I've seen come say, I never thought I would be without cigarettes, but they are. And that's through combination treatments and through vaping.
So, because I have here a question coming from the audience about around vaping, and I also have, because we have that space mainly in physical addiction to nicotine, but I think when you think about smoking, there's also some kind of psychological dependence on the fact of having a cigarette in your hands. So having this nicotine replacement seems to be something. The question from the audience, someone saying this seems controversial. I thought there was a lot of research showing the negative effects of vaping on our health. So that would be great to clarify. And the other thing would be, what could be the tactics, not just to have this nicotine replacement or like a kind of prescription to avoid smoking, but also a kind of psychological support to get rid of the dependency if there is
I mean, I have to be really clear that what I'm saying is you combine treatment with the support of a specialist, always. Not everyone will take that up, and you can still help that person by providing the best advice and information. But always you try and combine any treatment that you give with the support of a specialist who does behavior change, always. The vaping harms discussion, we could have a whole webinar on it. The issue with research into vaping is that you can't control for previous smoking. So if you say I'm taking a cohort of people that vape and a cohort of people that don't, the people that vape, more of them have heart attacks. Well, all of them are ex-smokers, and you can't compound for that. And then the other form of research is, well, we took a mouse and we put it in a box of vape, and there's some inflammation in their airways. And so we should be really cautious about vaping. I'm being a bit antagonistic here, and I agree, mice should never vape. But vaping is a replacement for smoking tobacco. And very, very rarely do researchers take active smokers who then switch to vaping and compare them to those that continue to smoke, because that's the difference you're looking at. The few people that do, like people who've published in the American Journal of Cardiology, who looked at markers of vascular health, really established markers. And at 30 days, the people that switched to vaping had a dramatic improvement compared to those that continue to smoke. Now, if you took someone who'd never smoked and made them vape and measured their vascular markers, there might be a negative impact. But it's about vaping as a treatment for tobacco dependency. And sadly, the research world has significant flaws with it that are not focused on it as a treatment for tobacco dependency.
I mean, this is good food for thought and probably a topic for further discussion in future webinars, because there are lots of things to do. So we still have five minutes left, but I would like to make one question before going to the conclusions and takeaway messages. So coming back to rehabilitation. So do you consider from your experience if there are any particular stages throughout the patient journey in which this pulmonary rehabilitation gains more importance? And if so, which ones would you consider the more important milestones through this journey? Not sure who wants to take the floor.
Well, maybe if I start, I mean, ideally it's a continuum, right? You get people involved from the point of diagnosis and they rehab, and then you get them up after their surgery, and they have 6 weeks to maybe focus on walking and exercise that is adapted to you know, how they feel after their surgery, and then they start into more vigorous activity. So ideally it's along the pathway. And in an ideal world, we would see patients from the point of diagnosis, and then we would know them and follow them. So I think, you know, when treatment is finished, be that surgery or other treatment, obviously when treatment is finished, patients might have more time, patients maybe psychologically feel more able to take on the concept of rehabilitation. But ideally that starts, you know, right from the beginning. And, you know, certainly we would see patients who don't, you know, we meet them maybe 6-12 months after any cancer treatments, and then you're trying to target side effects. So shortness of breath, fatigue would probably be the biggest one, and shortness of breath, and then the deconditioning, maybe the decreased in exercise tolerance and strength. And we will target them at any point, you know, after treatment. But the earlier we can see patients and the earlier we can get patients moving to keep it really simple, the better. So from a physical point of view and from their kind of their physical function point of view, ideally it's a continuum, and if not, it's as early as possible when treatment ends.
Yeah, I mean, I'd obviously agree with that. And I think from a different perspective, a different type of treatment. So if we've looked at surgery and that, you know, enables a certain type of prehab and rehab. I think when patients are going through intense treatment with, such as chemotherapy and radiotherapy together, they're often having treatment for 6 weeks continuously. So they're coming in daily for chemotherapy, for radiotherapy, which is an intense treatment to go through, just physically coming backwards and forwards to the hospital, plus the side effects and symptoms of the treatment itself. So we would want to optimize their fitness before they start that, to engage them into the program, engage them in terms of wanting to improve their fitness, wanting to sort of get into a pattern of doing things that become a bit of a routine. Nutritionally, you know, that's vital in terms of patients having radiotherapy to the chest, because that's unfortunately does affect people's swallowing at times, and that can cause problems with eating. So it's looking at things differently, looking at ways that they can improve their nutrition, not just in the way that we think about, you know, day to day before treatment, but how does treatment affect their eating? And then psychologically as well, you know, because the intense treatment goes on and becomes more tiring, they become more fatigued, more affected by side effects. It's important that we maintain their psychological well-being. So I think it changes, the need of the prehab changes as they go through treatment and then afterwards as well. So it's an important aspect of their care from start to finish, but I think the elements of it change as they go through it.
Right, thank you so much. So it's we have just a couple of minutes left. So just to before closing the session, I would like to ask every one of you for, like, after all the discussion, I think we can be speaking about this topic for hours and hours, but I would like every one of you to give like a takeaway message or a conclusion. So I would start all the way around. I will start with you, Grainee. So if you want to start first, please, what would be your conclusion, your takeaway message for our audience today?
I think from the point of diagnosis, to stay as active as you can. And we can keep it that simple, you know, just try and stay moving as you prepare for treatment and even go through treatment. And then after treatment, often it's to try and get that advice, and maybe sometimes you have to seek it out, and sometimes the advice is given as part of your care on how to manage those side effects. So fatigue or shortness of breath shouldn't be a reason not to exercise, but often it's trying to kind of get access to someone or meet with someone who could go through managing that with you, and how you can still be active around it, because the bottom line is patients who are more active, we do see better outcomes. And of course, so that's always our main message: avoid inactivity. Something is better than nothing, and that's the message we're trying to get out to everybody. But we do understand that some people need to meet with someone who can assess their breathing, assess their fatigue, and make adaptations for them.
Thank you, Grainee. So I will continue with you, Hilary.
Yeah, I mean, absolutely, exactly what Grainee said, and also it is something that patients can have control over. A diagnosis of lung cancer is the worst thing that somebody can hear, and not being able to do anything about that. But you're in the hands of the people that are looking after you, and the care that you're given and the treatment that you're given. So I think if you're able to take control of the things that you're eating, the activity that you can do, and your psychological well-being, I think is a huge part of your treatment. And from a caregiver point of view, I think the instinct for a person caring for somebody with lung cancer is to protect them, is to keep them at home, keep them from doing things, putting too much pressure on them. But actually, I think to live as normally as possible, and to do as much as you can, for yourself, I think is a really important part of your treatment.
Thank you so much, Hilary. And last but not least, Dr. Evison, if you'd like to add a few last words.
Yeah, so I agree completely with everything that's been said. I think the evidence for prehabilitation is overwhelming. There's no question now about whether it's the right thing. And I think the whole clinical community has a very, very strong will to see their patients have access to prehabilitation, rehabilitation. So our biggest challenge is about implementation and doing that at scale and making it a standard of care. And I really want to see a drive to system-wide solutions that are sustainable and resilient and can be scaled up.
Well, thank you so much. We are currently two minutes over time, but I think it was worth having these last takeaway messages. So before closing the session, first of all, I would like to thank the three of you, Dr. Evison, Hilary, and Grainee, for your time today. I think the discussion has been fruitful. As I said, I think we could be speaking about this topic for hours, because there are a lot of things, but I think it's been very interesting. I'm pretty sure our audience has really enjoyed the session today. Also, I would really like to thank everyone attending today's dialogue for being with us. And just before closing, I would like to remind that the full content of this dialogue has been recorded, and it will be uploaded to our YouTube channel in the upcoming days. We will also have subtitles available in French, German, Italian, and Spanish, so we can reach a larger audience. And also I encourage you to stay connected to our social media channels, like in Facebook, LinkedIn, Instagram, and Twitter, just to be aware of our upcoming activities. So being said that, I would like to thank you again for your time today. And I really wish you, everyone, a very lovely evening, and wish to see you in our upcoming activities. So thank you so much, and have a great evening.
Thank you.
Thank you.